Picture this. It is like 2 a.m.
Oh, the classic 2 a.m.
Right. The baby is miraculously asleep. The house is completely quiet. And you are just wide awake, staring at the glow of your phone screen.
Doom scrolling, essentially.
Exactly. You are deep into a search query that, honestly, you might feel too embarrassed to bring up with your doctor. Trying to figure out why, months after giving birth, your pelvic floor still just does not feel normal.
Yeah, and if you are in that late-night doom scroll right now, you really need to know that you are not broken.
No, not at all. But the medical narrative usually stops at the 6-week checkup, right?
Right. It leaves this massive gap.
A huge gap in our understanding of postpartum recovery. So today we are pulling from a bunch of really solid sources for this deep dive.
Oh, we've got the nice clinical guidelines, right?
Yep, nice guidelines, the POGP Physiotherapy Network's framework, that is the Fit for the Future one, and we are also bringing in insights from naturopathic and pelvic health experts.
It is a really well-rounded stack of information.
It is, and our mission today is to answer a question that honestly changes everything, which is, does weaning rebuild your vaginal tone and comfort?
It is such a vital question because that late-night search, it is practically a universal experience. We focus so heavily on the visible changes of birth.
Yeah, the stuff you can see.
Exactly. And we leave the invisible internal shifts completely unmapped. The assumption just becomes that whatever state your body is in at that 6-week mark, well, that is just your new permanent reality.
Oh, just terrifying.
Right. We end up navigating this really complex physiological terrain completely in the dark, just wondering if the laxity or, the discomfort is just the inevitable cost of having a child.
Okay, let's unpack this. Because to understand what happens to your vaginal tone and comfort when you stop breastfeeding, when you actually wean, we first have to establish the biological baseline.
Right, the before picture.
Yeah, what is happening inside your body during breastfeeding? We have to look at the endocrine environment that lactation creates.
You really cannot untangle the physical recovery of the pelvic floor from the hormonal environment. It is impossible.
So what is the defining feature there?
Well, the defining feature of the lactation environment is a profound suppression of the ovarian cycle.
Like it just shuts down.
Essentially, yeah. During pregnancy, your body is flooded with estrogen, sometimes 30 times the normal circulating amount.
30 times? Wow.
Yeah, it is massive. It supports fetal development, prepares the milk ducts, all of that. But once the placenta is delivered, that estrogen just drops off a cliff.
So it is gone almost instantly.
Right. And that drop acts as the biological signal for prolactin to take over. Prolactin drives the milk production.
But to keep making milk, the prolactin has to stay high, right?
Exactly. And as long as prolactin remains elevated, it actively suppresses the hypothalamic pituitary ovarian axis.
Okay, so it is basically telling the ovaries to just go to sleep.
Yes, it tells them to stay dormant, which completely halts the production of both estrogen and androgens, like testosterone.
So you go from an absolute flood of estrogen to this severe systemic drought.
A total drought, yes.
I really want to look at how this impacts the pelvic floor and the vaginal canal specifically, because a lot of the sources describe the state as feeling Sahara desert dry.
It is a common description, yeah.
But, weather metaphors do not really explain the actual mechanics of it. Like, estrogen is not just a reproductive hormone, right?
Right at all.
One of the sources described it like a site foreman on a construction project.
Oh, I like that analogy.
Yeah, so without the foreman, the workers, which in this case are the fibroblasts, they just sit around. They literally stop synthesizing collagen.
That is a much more accurate way to look at it. We were really talking about a state of temporary induced menopause.
Temporary menopause? That sounds intense.
It is.
Yeah.
The medical community actually classifies this as genitourinary syndrome of lactation, or GSL.
GSL.
Yeah. Because estrogen is fundamentally a tissue maintenance hormone for the entire genitourinary tract. It maintains the thickness of the vaginal mucosa, the blood flow, the elasticity.
So it keeps everything plump and stretchy.
Exactly. In an estrogen-rich environment, the superficial cells of the vaginal wall shed regularly, and they release glycogen.
And glycogen is food, right?
Right. That glycogen is the primary food source for your lactobacilli.
Right.
Those are the healthy bacteria that keep the vaginal pH acidic and, hostile to pathogens.
Okay, so take away the estrogen, and the entire production line just halts.
Completely halts.
The mucosa thins out, the fibroblasts go dormant, and that collagen scaffolding weakens.
Oh.
And without the cellular turnover, there is no glycogen, so the lactobacilli basically starve.
They do. And then the pH drifts toward neutral.
Mm-hmm.
which opens the door for opportunistic infections like E. coli or recurrent UTIs. What's fascinating here is how directly this temporary biological state clashes with the body's acute need to heal.
Oh, right, because you just gave birth.
Exactly. You have just experienced major trauma to the pelvic region. Whether that is a vaginal delivery that stretched the pelvic floor muscles to their absolute physiological limits,
Or perineal tearing.
or a major abdominal surgery like a C-section. At the exact moment, those tissues desperately need cellular turnover, increased blood flow, and robust collagen synthesis to rebuild.
They're being starved of it.
Right. They're actively deprived of the very hormone that orchestrates that repair.
It just creates a perfect storm for chronic discomfort. I mean, the tissues are thin, they are poorly vascularized, and they lack the structural integrity to handle even normal friction.
Yes, exactly.
The clinical sources really point to this as the primary driver behind postpartum pain during sex.
Absolutely.
But it is not just intimacy. Even everyday activities like, I don't know, wearing restrictive clothing or the friction from a long walk, that can cause microabrasions in that thinned out mucosa.
It is so sensitive.
Hmm.
And on a deeper muscular level, the pelvic floor itself just feels less resilient.
Because of the collagen.
Right. The ligaments supporting those muscles are literally starved of the collagen they need for tensile strength.
Which brings us to the pivotal transition, right? Weaning.
The big shift.
If the high prolactin of breastfeeding is suppressing the ovaries and keeping those fibroblasts dormant, then weaning has to be the biological trigger that reboots the entire system.
Yes. As you reduce the frequency of feeds, the brain registers the decreased demand,
Okay.
and prolactin levels finally begin to fall.
And when prolactin falls?
It lifts the suppression on the hypothalamic pituitary ovarian axis.
Oh,
The ovaries finally wake up.
wow.
And then we see this gradual, sometimes turbulent, but steady rise in estrogen and progesterone. For the genitourinary tract, this is the all-clear signal to resume normal operations.
The foreman is back on the construction site.
Exactly. Blood flow returns to the vaginal tissues, and those dormant fibroblasts get the chemical signal to start synthesizing collagen again.
So the vaginal walls begin to regain their thickness. The natural lubrication improves.
And the lactobacilli repopulate to drop the pH back down.
That is incredible.
The speed of that physical rehabilitation can actually be quite remarkable once the estrogen baseline is restored. The burning, the irritation, the structural laxity, it all begins to resolve because the tissue is literally rebuilding its own infrastructure.
No, okay, here's where it gets really interesting.
Oh, yeah?
Yeah, I was digging into the POGP physiotherapy notes on vaginal tone. There is this pervasive myth that if you are experiencing pelvic organ prolapse symptoms postpartum, your pelvic floor is just permanently broken.
Oh, the overstretched rubber band myth.
Yes, like a rubber band that will never bounce back. But the sources explicitly state that weaning actually improves pelvic floor dysfunction.
It really does. The assumption of permanent structural failure completely ignores the dynamic nature of human tissue.
Right, we are not rubber bands.
No, we are living tissue. The muscles and ligaments of the pelvic floor are highly concentrated with estrogen receptors, and collagen is the vital building block that gives your pelvic ligaments their elasticity and their load-bearing strength.
So as estrogen rises during the weaning process,
That support network is chemically signaled to rebuild itself. You literally regain measurable tensile strength in the ligaments holding up the bladder, the uterus, and the bowel, simply because the body finally has the hormonal tools to repair the overstretching that happened during birth.
okay, I am going to push back on this a bit, though.
All right, go for it.
Because looking at the naturopathic and physiological sources, there is a massive paradox here.
Okay.
If the physical machinery is optimizing, right? If the collagen is rebuilding, the tone is returning, the natural lubrication is back, why is weaning so often accompanied by a severe drop in libido, intense mood swings, and just this feeling of profound physical disconnect?
That is the big question.
Like, if the body is finally fixed physically, why is the brain suddenly crashing?
You are hitting on the psychological and neurological paradox of weaning right there. While your pelvic floor and vaginal tissues are down there celebrating the return of estrogen, your central nervous system is going through a brutal chemical withdrawal.
A withdrawal. From what? The prolactin?
Prolactin and oxytocin. Lactation is maintained by prolactin, which actually has a deeply sedating, calming effect on the brain.
Oh, I didn't know that.
Yeah, and oxytocin, which promotes bonding and contentment. So when you wean, you are abruptly cutting off a steady, round-the-clock supply of those powerful neurochemicals.
Wow. So it is like having a sports car with a brand new rebuilt engine, but the driver is dealing with a terrible flu and has absolutely zero desire to take it out of the garage.
That is a perfect way to put it. The physical capacity for comfort is there, but the neurological drive is completely absent.
That makes so much sense.
That withdrawal triggers massive destabilization in the brain's neurotransmitter baseline. The sudden absence of prolactin and oxytocin can precipitate intense post-weaning anxiety, insomnia, irritability, and even depressive episodes.
That sounds completely overwhelming.
It is, and furthermore, as the ovaries wake up, the fluctuations in estrogen and progesterone can be highly erratic before they settle into a predictable cycle.
Leading to like severe PMS symptoms.
Exactly. So while the vaginal tissue is physically more capable of comfortable intimacy than it has been in months, your brain is navigating exhaustion and chemical depletion. The neurological bandwidth required for libido simply is not there.
And this just compounds the mechanical stress of weaning, right? I mean, managing a baby's shifting sleep schedule, potential guilt about ending the breastfeeding journey, the physical discomfort of the breasts themselves.
It's a lot all at once.
The sources make a really strong case against abrupt, cold turkey weaning unless it is medically necessary. Not just because of the physical risk of severe engorgement mastitis, but because of the violent neurological whiplash it causes.
Gradual weaning is essential. It allows the endocrine system to titrate that hormonal shift. It gives the brain time to upregulate its own dopamine and serotonin production as the prolactin and oxytocin fade away.
And it gives the physical body time too, right?
Yes, it gives the pelvic tissues a runway to slowly begin that collagen synthesis.
Right. Since this hormonal recalibration does not happen overnight, I mean, it can take weeks or months for the estrogen to fully synthesize that new collagen. We have to look at how to actively manage vaginal tone and comfort during this transitional window.
If we connect this to the bigger picture, your body is in an active, dynamic state of rehabilitation.
Prehab. I like thinking about it that way.
Yeah. We would never expect, say, an ACL tear to fully heal without targeted physical therapy. Yet we routinely expect the pelvic floor to just somehow snap back without any intervention.
Which is ridiculous when you think about it.
It is. It requires both mechanical loading and topical support while the hormones stabilize.
Okay, let's dive into the mechanical loading part, specifically pelvic floor muscle training, or PFMT. The NHS and POGP guidelines are very clear that this is not just indiscriminately squeezing whenever you remember while you are waiting in line for coffee.
No, definitely not. The pelvic floor is a really complex muscular hammock. It is composed of different types of fibers, and you have to train them specifically.
Yeah.
Well, the muscle architecture dictates the training. The pelvic floor consists of slow-twitch fibers, which are responsible for endurance.
Okay.
They are like the marathon runners, holding your pelvic organs in place against gravity all day long. Then you have the fast-twitch fibers, the sprinters. They provide immediate power to clamp shut the urethra when sudden intra-abdominal pressure hits, like during a sneeze or a cough.
So effective TFMT has to target both pathways.
Exactly.
So for the slow twitch fibers, the protocol requires endurance holds. You actively squeeze and lift the pelvic floor, and the cue they use in the sources is imagining you are trying to stop passing gas and urine simultaneously.
Yep, that is the standard clinical cue.
And you hold that contraction for like 5 to 10 seconds. The key is breathing normally without bearing down.
Breathing is crucial there.
Right. And by doing these sustained holds, you are creating micro tears in the muscle fibers. And as that estrogen slowly returns during weaning, it uses those micro tears as a literal scaffold to lay down the new collagen.
Exactly. And then you follow that with power training for the fast twitch fibers, which are quick, 1-second maximum effort contractions followed by a full release.
The full release is critical.
Highly critical. A muscle that cannot fully relax cannot fully contract. Hypertonic or overly tight pelvic floor muscles can cause just as much dyspareunia and dysfunction as weak ones.
Oh, that is a really good point.
Apps like Squeezy, which is actually recommended by the NHS, they're designed to guide the pacing of both the contraction and the necessary relaxation phases.
That is such a helpful tool. Now, beyond isolated exercises, the physical therapy sources emphasize integrating this into functional daily movements. And the knack is a perfect example of this.
Ah, yes, the knack.
It is like a preemptive mechanical strike. You consciously engage and lift the pelvic floor milliseconds before you cough, lift a heavy car seat, or laugh. You are actively bracing the structural hammock before the pressure forces it downward.
It acts as a protective mechanism for the ligaments. While those luteins are still waiting for peak estrogen to fully restore their tensile strength, the knack prevents them from being overstretched repeatedly throughout the day. It mitigates the daily wear and tear.
Another functional protection mechanism is toilet posture.
This is a big one.
Right. We rarely think about the physics of the bathroom, but straining while sitting at a standard 90-degree angle forces the puborectalis muscle to literally choke the rectum, requiring massive downward pressure to overcome.
Which is terrible for the pelvic floor.
Exactly. Using a footstool to elevate the knees above the hips shifts the anatomical angle. It aligns the colon so gravity does the work. You remove the need to bear down, which protects a recovering pelvic floor from intense, unnecessary strain.
Mechanical protection is half the battle. But the other half is topical support for the mucosal tissues that are still recovering from the GSL, the genitourinary syndrome of lactation.
Right, because the dryness is still there.
Exactly. While the ovaries are ramping up estrogen production, the localized dryness and thinning need direct intervention.
The sources outline a tiered approach to restoring that topical comfort. It starts with non-hormonal interventions. So, during intimacy, high-quality water-based or silicone-based lubricants are just non-negotiable to prevent microabrasions and reduce friction.
Absolutely non-negotiable.
But treating the tissue only during sex is insufficient, right? Routine, daily vaginal moisturizers act similarly to how you would treat dry skin on your face. You wouldn't just moisturize once a week.
Right. Moisturizers formulated with hyaluronic acid are particularly effective here.
Because it holds so much moisture.
Exactly. Hyaluronic acid is a humectant that can bind massive amounts of water relative to its molecular weight, drawing moisture directly into those dehydrated mucosal cells. Applying a pricked vitamin E capsule directly to the vulvar tissue also provides this great occlusive barrier that soothes the skin and prevents moisture loss.
But for cases where the dyspareunia is severe, or the dryness and irritation are causing daily distress despite all these moisturizers, the clinical guidelines point to local vaginal estrogen as a highly effective medical intervention.
Yes, they do.
And I want to be very precise about this because the word estrogen often triggers anxiety about systemic side effects or concerns about suppressing milk supply if someone is still in the process of gradual weaning.
That is a very valid concern, but the pharmacokinetic profile of local vaginal estrogen is entirely different from systemic hormone replacement therapy.
How so?
When introduced locally, like via a low-dose cream, a small tablet, or a silicone ring, the estrogen is absorbed directly by the vaginal and vulvar mucosa. It binds immediately to those local receptors to stimulate blood flow and cellular maturation.
So it does not go everywhere else.
No, the systemic absorption into the broader bloodstream is clinically negligible.
Okay, that is reassuring. However, the clinical caveat noted in the NHS and naturopathic literature is that any introduction of estrogen, even locally, warrants a conversation with a healthcare provider, especially if the goal is to maintain a specific milk supply during the final stages of weaning.
Always talk to a doctor first, yes.
It is really about weighing the profound quality of life improvements like the eradication of daily burning and the return of tissue elasticity against individual clinical profiles.
For many individuals, that localized low-dose intervention bridges the gap perfectly. It provides the necessary foreman to the localized construction site, rebuilding the tissue health, while the rest of the endocrine system takes its time recalibrating the systemic hormones.
So what does this all mean? When we synthesize the clinical guidelines, the biomechanics of the pelvic floor, and the neurochemistry of the weaning process, a very clear narrative emerges.
It really does.
The structural laxity, the severe dryness, the drop in libido, these are primarily temporary, hormone-driven states dictated by the biological demands of lactation and the subsequent withdrawal. They are not permanent structural failures of your anatomy.
Recognizing the temporality of these symptoms completely changes how you approach recovery. The end of lactation triggers the return of estrogen, which naturally orchestrates the rebuilding of collagen, the restoration of elasticity, and the repopulation of healthy lactobacilli.
But it takes time.
Yes, it is an architectural project that requires time, mechanical rehabilitation through targeted PFMT, and topical support to bridge the gap.
And it also requires immense grace for the neurological crash. I mean, the brain is recalibrating from the loss of prolactin and oxytocin, meaning your emotional baseline and your libido are going to be in flux, even as the physical tissues repair themselves.
This raises an important question about our fundamental understanding of postpartum timelines.
Oh, absolutely.
The medical establishment revolves around a 6 to 8 week discharge model, treating recovery as an acute, short-term healing of visible trauma.
Which brings us back to that 2 a.m. search.
Yeah.
We feel broken because we are judging our bodies against a timeline that is biologically fictitious.
Fictitious is the perfect word for it.
Based on the physiology we have explored today, a mother's pelvic floor integrity, her tissue resilience, and her neurochemical baseline are entirely anchored to her lactation status. So I want to leave you with a final thought to mull over.
Go ahead.
If full physiological recovery, the true rebuilding of the collagen matrix, the restoration of mucosal thickness, and the stabilization of the central nervous system is biochemically blocked by prolactin and only truly begins after the weaning process is underway. And that weaning might happen 8 months, a year, or even 2 years down the line. Shouldn't we radically redefine what the postpartum period actually is? Perhaps the postpartum era is not just a few frantic weeks of acute healing. Perhaps it is a multi-year biological epoch, a long-term physiological transition that only truly concludes long after your baby's very last feed.